Did you know that one of the best ways to assess your risk of breaking a bone is to get your bone density tested? Hi, my name is Anita Kaiser, and this is episode 4 of the Bare Bones podcast. I See Your Skeleton, where we'll talk about bone density scans. Joining me is my colleague Wendy Murphy, who has over 30 years of experience living with a spinal cord injury, and our guest, Dr. Karen Troy, a professor of biomedical engineering at Worcester Polytechnic Institute in Massachusetts. Welcome to the show, Dr. Troy.
Thanks for having me.
So when people with spinal cord injuries talk with their doctor about their bone health, they will often hear their doctor use the term bone mineral density, or BMD for short. Can you please explain what bone mineral density is and how does it change after spinal cord injury?
Of course. So our bones contain mineral, mostly calcium, which is what makes them stiff and strong. And bone mineral density is a way to measure how much mineral is present in our bone at a particular location. So what we know also is that bone likes to be loaded. And normally, as we walk around as an able-bodied person, your bones, especially in your legs, are being loaded every day. But after you become spinal cord injured, you've probably shifted to loading your bones a whole lot less. And so what we find is that, especially in the first 2 years after injury, when we're less weight-bearing or even non-weight-bearing, people tend to lose bone quite rapidly until it reaches a new steady state. So after that 2 years, there's really not that much change. But there's a huge amount of individual variation in how quickly we lose that bone and how much bone we lose. And we also know that men and women tend to lose bone at about the same rate, but because women tend to be smaller to begin with, they can end up with weaker bone at the end of the day.
Tell us, why is it important to measure BMD following SCI?
So, as I mentioned, everyone loses bone at a different rate, and we all start with a different amount of bone. So without measuring our bone mineral density, we can't really understand what our fracture risk is. So we have to just look.
So thanks for explaining the importance of why we need to get our bone mineral density measured. And I know there are different ways to do this. Can you tell us a bit about them?
So the two primary ways that you will hear about for measuring bone density are DEXA, which stands for dual energy X-ray absorptiometry, and PQCT, which stands for peripheral quantitative computed tomography. So both of these methods use X-rays, and the main difference has to do with whether they're two-dimensional or three-dimensional pictures of your bone and exactly how the measurement is taken. So in North America, the most typical way is DEXA, and sometimes we just call this a bone density scan. It involves laying on a table, and then they take a picture of your whole bone. So it looks just like an X-ray, but it's quantitative, so we can actually get a number out of that X-ray value. PQCT is a little bit different. It's actually taking a three-dimensional picture of your bone, but just a little slice of your bone. So usually PQCT would be used on your lower leg. Maybe they take a measurement around your ankle and kind of the mid part of your shin and maybe as high as your knee. In those situations, there's a little machine. It often sits in a doctor's office or a clinic with a ring, and you have to stick your arm or your leg into the center of that ring, and then the measurement is taken. So they can measure different body parts.
Now, what regions or areas of the body are important to measure for people with spinal cord injury?
So the goal with all of these measurements is to prevent fractures. And because of that, it's most important to measure the locations where fractures most frequently occurred. So with people with spinal cord injury, the knees are really important because that's where people often tend to get fractures.
As you know, doctor, living with a spinal cord injury can bring on some daily challenges. Let's say I wear a leg bag, have strong spasms or contracture, or maybe broke my leg when initially injured and have hardware. Tell me, can I still be tested?
Yes, but the methods and the sites may need to be adjusted. For example, some of these items can interfere with the x-rays and we can just move them out of the way like a leg bag. But sometimes we need to adjust how you're positioned so that we can get a good image of the bone that we're trying to understand. Especially if you have fracture fixation hardware, it may be that we can't measure your left leg, but we could measure your right. So there's a lot of creativity that the scanner technicians can use to try and help to get a measurement at the best site.
That's nice to know, because I know a lot of people with spinal cord injuries are dealing with at least one of those issues. So it's good to know that there are ways around that. So I know that after you get a bone density test with DEXA, your doctor will provide you with a report that will tell you about the health of your bones. And that report provides two measures, a T-score and a Z-score. So in basic terms, can you please explain what those scores mean and when would a person need to be concerned about their bone health?
Sure. So both scores are giving you what's called a standardized measure. So they're comparing your bone density to bone density from a population. And a score of 0 is going to tell you that you have the same density as the average of that group. A positive score, so a +1 or a +2, would mean that your bone has higher density than the comparison group. And a negative score, -1, -2, would tell you that you have lower bone density. So each of those units is one standard deviation away from the mean value. What that means is that when we look at a range, +1, -1, that's pretty normal. T-score in particular, the comparison group is a young adult at peak bone mass, so about age 25. So we would usually look at T-score for older adults when we think about diagnosing osteoporosis. That's age-related. So we want to compare to a young, healthy group. But T-score really isn't a very useful comparison if you're in that age group. So instead, we look at Z-score. Z-score is compared to an age-matched adult. And so this is the best measurement for younger adults, especially those under age 40. So you might be told that you have low bone mass for your age, but you're not actually going to be diagnosed with osteoporosis, even if you're very low, because that's not actually a valid diagnosis for somebody who's younger. So in terms of when to watch out, a value of 0, again, means that you're average. Even if you're at -1, that's a pretty normal range.
So I think like along those lines, like at what score value, I guess, would your doctor just sort of be monitoring? And then what score would actually prompt my doctor to actually develop a treatment intervention? And then say, for example, if I was undergoing treatment, how would I be able to tell then if the treatment was working?
Approaching -2, I would certainly be paying attention. Once you get to a score of -2.5, that would be a cutoff value at which we would say you really have to start to think seriously about interventions and having a conversation with your healthcare provider as you get close to -2 and beyond. In terms of determining whether a treatment is working or not, this is one of the reasons that getting regular bone density assessments is important. We would recommend getting bone density testing every year. That is going to allow you to see whether you're continuing to lose bone or whether you're actually gaining bone or whether you're just at steady state.
You're sharing some really great information. Now tell me, is there a point where I should avoid certain types of exercises, like standing, for instance?
There's no specific cutoff at which we say you should not do certain types of exercises. Everything is going to be a conversation about your individual risks and benefits. Certainly, when you have a very low T-score or a very low Z-score, there would be additional risks that could be associated with certain things. And so it's worth having that conversation. But there's no hard line about this because exercises will often have a benefit to bone. And so we don't want to prohibit somebody from doing something.
So I want to switch gears a bit and talk about QCT. And I know there are two types, QCT and PQCT. What is the difference between them?
Yeah, so QCT stands for quantitative computed tomography. And as I mentioned before, PQCT is peripheral quantitative computed tomography. So they use the same technology. They both use X-rays to take a three-dimensional picture of bone. From that three-dimensional picture, we can analyze things about the geometry of the bone And we can also understand how the density of the bone is changed over a region. So the main differences are that PQCT is peripheral, which means that we can only measure the ends of a limb. Typically, we'd be measuring around the ankle, maybe up to the knee or your forearm and wrist. With QCT, that actually uses a CAT scanner and takes that image and analyzes it quantitatively. So we'd get numbers out of that CAT scan. Because it's using that CAT scanner, there's usually a higher dose of radiation because you're getting a bigger region. But it also means that if you were going to be getting a CAT scan for some other reason, we can sometimes do QCT analysis on that scan without having to go to any extra work.
So then tell me, Dr. Troy, why would someone choose to get QCT or PQCT instead of DEXA?
There are two main reasons. The first reason has to do with availability. QCTs are often done opportunistically, meaning that if you're already getting a CAT scan for another reason, we can do a QCT analysis of the bone at that time. PQCT is often more available. The second reason has to do with the three-dimensional nature of these scans. DEXA gives you a two-dimensional picture. It looks just like an X-ray that you might see. QCT and PQCT tell you about the three-dimensional structure of the bone. And that can help us to understand whether a bone might be weaker or stronger. So it can help us to better understand fracture risk.
Now, is one safer than the other?
QCT, because it usually involves more X-rays to get a three-dimensional picture of a bigger region, can be associated with a higher radiation dose. I think the reason that you get concerned about radiation exposure is because we should be minimizing it. And especially if you're a younger person who's thinking about a family, then that would be something to avoid. The radiation dose for PQCT and for DEXA is very low. The benefits of having that bone density information far outweigh the risks of the radiation.
So are there any challenges with measuring your bone density using a QCT or PQCT machine?
The presence of an artifact. So if you have fracture fixation hardware or something else that interferes with the X-rays, that can also interfere with the measurements. And then positioning yourself in order to get the measurement can be a bit tricky, especially if you're having issues with contractures or spasticity. So most technicians are pretty creative, and we can almost always find a solution, but it can be a bit challenging.
So to end things off, what would be your take-home message that you want people to remember?
Yeah, I think it's really important to get your bone density tested, get it tested on a regular basis, and make sure that you're having it monitored around your knee region.
Thank you, Dr. Troy. So if you found today's talk interesting, check out our action planning tool on the website at www.sceifragments.ca. And feel free to send us your feedback using the survey provided on the website. In the next episode, we'll talk about vitamin D, calcium, and bladder and kidney stones.